Good morning, everyone. This is the COVID-19 weekly update with VDH Central Office and local health districts for March 19th, 2021. The meeting will run from 11 a.m. to approximately 12:30 p.m. Just a reminder, you will be muted upon entry. Please refrain from unmuting yourself during the call. This call will be recorded. Please type any questions for presenters in the chat box or email them to donald.moore@vdh.virginia.gov with the subject line LHD call question.
Can you hear this or no? Okay. Yeah, just
Today's
you don't.
someone's unmuted. You need to mute yourself, please. Today's agenda will start with an admin announcement, followed by updates from the vaccination unit, other PH ops, DCLS, modeling, and any questions using chat. Admin announcements. Given competing demands for meetings, today will be our last combined Friday local health district call. As we have moved through the pandemic, many units have established their own meeting cadence, and based on feedback we've received, this meeting is serving more as a compilation and, in some instances, a duplication of the week's progress/updates. Moving forward, the vaccination unit will provide their updates through the VDH Agency Forum, a weekly technical assistance/vaccine planning update each Wednesday at 9 a.m., and the vaccine unit fireside chat, Wednesdays at 11 a.m. following the vaccine planning update. Other meetings regarding vaccination activities will be had on an ad hoc basis. For dial-in information for the Wednesday meetings, please email marshall.vote@vdh.virginia.gov. The other PH Health Operations Unit will shift back to utilizing their long-standing state EpiCall on the first Tuesday of each month. Additionally, other PH Ops will provide critical updates through their weekly epidemiology fireside chat and through the health information team's daily email. The testing, modeling, and community mitigation units will participate in the relevant fireside chats as required or requested. The modeling unit, including staff from RAND and UVA Biocomplexity Institute, hosts a weekly update every Thursday at 12 noon. Please contact Emily Sheffield, emily.sheffield@vdh.virginia.gov to be added to that invite. And as always, we will schedule statewide calls outside of these time blocks to discuss emerging issues related to the response. We thank you for your flexibility and attendance of these Friday calls. Now, we'll have the vaccination unit update by Marshall Vote. Marshall, will you please take the call?
Great. Thank you so much, Donald. If we could go to the next slide, I'll cover today's agenda before we get into the material. We'll be talking about some updates to the vaccine campaign, including a quick overview of community vaccination centers, resources for the vaccination of school child care staff that are a priority for vaccination, the reporting of any deficiencies with ancillary supply kits, some additional data reporting reminders, and pharmacy updates. I have a training plan update to present to you on behalf of Susie Silverstein, and of course, vaccine administration system updates, VAMS and PrepMod, and then I'll turn it over to M. Stevens, who has some updates on a data visualization dashboard for vaccine campaign progress. To go to the next slide, we'll dig into the content now. As you are probably aware, community vaccination centers launched this week in Danville, Portsmouth, and Colonial Heights, Petersburg, at Virginia State University. These are large mass vaccination sites that are administered by a contractor, but they use our state allocation. We have a couple additional planned community vaccination centers in Prince William, as well as Suffolk and Wise. I do believe that there are perhaps going to be some changes with the start dates for at least the Wise Clinic. and I heard that this morning on a call, so this slide is not entirely accurate. Remember, these operate as closed point of dispensing sites that are designed to complement ongoing vaccination efforts, and they've really been located strategically with a health equity lens. They are going to schedule their appointments as closed pods through the VACE, or Vaccine Appointment Scheduling Engine system, and registration and vaccine administration are recorded on-site via PrepMod. If we go to the next slide, reminder of other kind of priority population groups that we are looking to vaccinate. Consistent with President Biden's directive to ensure prioritization of COVID-19 for teachers as well as school and child care staff as a way to facilitate reopening schools, Virginia is prioritizing vaccinations for this group in 1B. We have been prioritizing them. I think many teachers and school and child care staff are at the very beginning of phase 1B for many districts. But again, we want to make sure that they are prioritized in all of our public health vaccination clinics. Pharmacies have also begun to prioritize individuals in these groups, and there's a great resource kit available at that link, which takes you to the CDC website if you wanted to do any additional outreach or messaging for that. On the next slide, we realize that sometimes when vaccine comes out to providers and the ancillary kits arrive with that vaccine, that there are issues with those ancillary kits. If you do find deficiencies in those kits, or providers find deficiencies in those kits, please shoot an email to covidvaccineinfo@vdh.virginia.gov, and we will be able to liaise with our federal partners and report that. If you have an error or injury resulting from any of these supplies in the ancillary kits, please do report that to theirs. And if it does involve a syringe, because those are medical devices, there is an FDA Form 3500 that needs to be reported as well. And you can see the links for both theirs reporting and that FDA reporting on the slide. And the next slide has some additional important reporting reminders. This really centers around data. All providers, so local health departments and community providers, need to be reporting their daily vaccine inventory into Vaccine Finder. They need to ensure that their doses administered are being reported to VIS, again, through direct entry, utilization of VANS or PrepMod, or through an electronic health record or other system that is communicating with VIS. And of course, anytime you redistribute vaccine, please let us know about that. In addition, local health districts, as they're planning vaccine events, please complete that survey there. That's very important for us to gather that data so we're able to report that up to the Secretary's office for use in briefing for state leadership. Go to the next slide. We'll talk now about the Federal Retail Pharmacy Partnership Program and the Long-Term Care Facility Pharmacy Partnership Program. First, on the Federal Retail Pharmacy Partnership, or FRPP, again, the criteria for vaccination has now expanded to all of phase 1B. At pharmacies. Pharmacies should continue to prioritize vaccinations for those that are 65 and older, and school and child care staff, but all phase 1B individuals are now eligible to be vaccinated through pharmacies. Pharmacies are working to kind of pivot to this expanded 1B criteria by updating their websites, their vaccine appointment scheduling systems, all that good stuff. And we're excited that's going to increase this channel for administering phase 1B vaccines. Of course, we need pharmacies to continue to report their on-hand inventory and any links for online appointment schedulers to Vaccine Finder. Next week, the allocation for Moderna and J&J is going to remain the same, but nationally, so here in Virginia as well, we will see a slight increase for pharmacies receiving Pfizer vaccine. We're also going to be working with pharmacies to try to coordinate vaccination of grocery store workers. Again, those are really individuals that would be in 1B and hopefully have been vaccinated, or we're working to get them vaccinated, but we believe that because a lot of pharmacies are co-located within grocery stores, this is a good way to potentially vaccinate grocery store workers. Data reporting is critical, so again, all doses must be reported to VIS, preferably within 24 hours. On the next slide, just some notes on the Long-Term Care Facility Bridge Program. As you all are aware, CVS and Walgreens have gone through and done their 3 vaccination clinics at a lot of the long-term care facilities in Virginia. We realize that hasn't hit everybody, though, and so we are continuing, and by we, I mean the pharmacy and long-term care facility group in the vaccine unit. They're really doing astounding work to coordinate those ongoing needs. So we are working, or they are working rather, to identify and to meet ongoing needs in terms of getting vaccine doses to individuals in the long-term care facilities that need them now that CVS and Walgreens are done, and also to enroll and launch long-term care pharmacies with the vaccine so that we're able to not have to do kind of these one-offs as much. We're getting good responses from local health districts is what this group is reporting, and they will continue to reach out and work with the health districts in the coming weeks to try to address these needs. The next slide now, we'll talk about some changes to our training program. You can see there that link will take you to some wonderful just-in-time training resources. And what you can do is actually copy and paste that link and make a shortcut on your tablets or your computers, so it's easy for you to go to that web page or hand a tablet or a computer to somebody and they can go to that web page and access just-in-time training. Topics there include PrepMod. You can see there's some specific modules there for the PrepMod system, as well as a great video about preventing needle sticks that actually goes through the different types of syringes and safety devices on those syringes that are being used at mass vaccination clinics. If we go to the next slide, there's going to be some upcoming information about community vaccinators. As you're probably aware, both the PrEP Act as well as some pieces of legislation in the General Assembly session in Virginia have really expanded the ability for people to provide vaccinations across different roles. Some people that may have retired or recently expired licenses will be able to provide vaccine. There's going to be more information coming about this, but there's some great training for these individuals as they start onboarding to become vaccine providers. So you can see that link there will take you to some great resources about who is eligible to vaccinate, and then some of the training plan and checklists and courses for those individuals. And on the next slide, you'll see kind of a matrix here. It's kind of in small print, but this is on that website as well, and it kind of breaks down both through VDH and through non-VDH vaccine providers who can vaccinate and what rules and stipulations are there. Finally, if we go to this next slide, you'll see some additional training resources on community vaccination clinics. This is kind of a good overview and essentials course for community vaccination centers. So if you're having people that are going to be assisting you with CVCs, this training course is a great way to kind of provide a primer for those individuals. And finally, on the next slide, just a reminder that there are education concierges available, and they are broken down by region, and Jessica Waugh is over the overall kind of education and training program. So there's contact information there if you need to find your education concierge and have questions, concerns, or requests for additional training. If we move to the next slide, I'll present some VAMS updates and then PrepMod updates. VAMS 2.2 was released this past weekend and does include some great new features, including enhancements that are specific to the Johnson & Johnson vaccine, the ability for a recipient to update their vaccine appointment without losing their current appointment, a reduced number of screens and clicks to be able to log vaccine administration if you're a provider, as well as enhancements to the contact center or assisted registration functionality, the ability to do a lot more in terms of third-party data exporting, and the addition of some additional demographics and a simplified landing page. So we're very happy with this upgrade of VAMS, and for those districts that are still using VAMS, we think this will be very beneficial. I'd also like to note that the landing page, when you actually get an email to register for an appointment, it used to say if you already had an account with the VAMS system, and a lot of people were getting very confused because they thought that their pre-registration account was the same as their VAMS account. That's not the case. They were clicking yes, and it was preventing them from being able to log into the system. I reached out to CDC, and they have made those changes. So hopefully for those districts using VAMS, those individuals getting emails to schedule an appointment are not going to be having those problems and having some of that confusion. Go to the next slide now. Before we go into the PrepMod updates, just an overview again. We know different districts are using different systems, so we're thinking of this as a toolbox. We are striving to provide a toolbox of various systems that you can use, including PrepMod, VAMS, paper and counter forms if you need to use those, as well as the Virginia Vaccine Appointment Scheduling Engine, or VACE. Each district is basically using what works for them, and at this point we don't have plans to remove any of those existing tools. And if those plans change, we will let you know and provide ample time so that a changeover can occur. A reminder that VACE is that scheduling tool that can send text and emails to patients. We're using it right now for community vaccination clinics and some retail pharmacies, but it may be available for limited district usage in several weeks, especially as we enhance it to perhaps be able to collect actual vaccine administration information and communicate that to VIS. So just a summary here, you have a variety of different systems available to you. Please use what works, because the goal is to use a system that works for you to get vaccine into arms. One of those systems, of course, is PrepMod, and on the next slide, you'll see there have been some enhancements and fixes to PrepMod. I'll call your attention to that third body of text there, which is the bulk upload and unique URL. I never thought that I would see the day at one point, I'll be honest, but I'm happy to report that bulk upload functionality and a unique URL for clinic invitation emails has been deployed to PrepMod, has been tested extensively, and it does work. We'll talk in another couple of slides about how we're going to roll this out, because we want to make sure that this feature is working and is locked tight before we roll it out widely. There's a training video there at that link that gives more information about that functionality. You can see there's another couple fixes that have been made in PrepMod for users that are trying to schedule appointments and for users that are navigating the system. If we move to the next slide, here is just some information about training courses for PrepMod, as well as upcoming office hours. You can see that there are office hours held almost daily. Dana Payne is going to be your best point of contact for support when it comes to PrepMod and training, but please continue to copy Nitin and Sue as well. With an increase in weekend clinic activity, there's also going to be a schedule for on-call weekend support for PrepMod. So as I mentioned, if we go to the next slide, we are going to be phasing in the bulk upload and one-time private clinic use link for PrepMod. We want to pilot this to really stress test this and make sure it's going to work and it's going to work correctly. But you can see there is a timeline for that kind of full rollout decision to be made by next Friday. So we're going to be working on this, really making sure that it works and it works sufficiently. If it doesn't, we may decide to step back from that, but we're hopeful that this functionality is finally going to be out there for you all to use. And finally, if we go to the next slide, again, my sincere thanks. As Donald mentioned at the beginning of this call, this will be the last vaccine unit update on these, the last of these weekly local health department calls. However, we do have a Wednesday kind of technical assistance and planning update for those that are really involved with the vaccine operations. And then we have a fireside chat afterward at the 10 o'clock hour so that we can discuss certain topics more in depth. If you are interested in joining those, one, I'd encourage you to reach out to kind of the leads for vaccine updates and vaccination operations in your district. They probably have the WebEx link. It's one link for both of the meetings. They run just kind of concurrently, so you can come to one, the other, or both. And they are recorded and on the internal web page. But if you're not able to find somebody who has the link, shoot me an email, and I will be happy to send you an invite. Thank you all for all of the hard work that you've done. And for those of you that want to continue to hear my voice, I'm happy to record ASMR videos if you would like them, touch base with me offline, or join us on the Wednesday calls. Thanks so much, and I'll turn it back to Donald to turn it to M for some updates on the vaccine dashboard and visualizations.
Now, M. Stevens will update us on the vaccine operational dashboard, which Marshall just said. M, will you take the call, please?
Absolutely. And Marshall, I think I'm going to follow up with you on those ASMR videos.
I'm still recovering.
All right. So we do have a new dashboard available at this point. There's a link here and a password. It is on the external VDH site. It is password protected. We ask that you keep it internal as much as possible, but it is available here for partners who are outside of the VDH network. So VDEM partners, Deloitte partners should all be able to access this dashboard at this location. It includes the current administrations and targets to reach 75% coverage by set dates, target dates. I'll note here that there is an about the data section, but the administrations are included are those that are first doses only to be a proxy for the number of people that we have vaccinated. And it's only among people 18 plus, just to make sure that we are kind of making things as level as we possibly can in terms of that playing field. The data are cut off 4 days prior to the date that the report is run, just to allow time for those records to trickle in, allow time for data entry and data cleaning and processing. The targets are defined algorithmically, just as what's necessary in order to reach the 75% targets by the set target dates. And I'll talk a little bit about that calculation here in just a second. Next slide. Right, it's a little small here, but I have some screenshots from the dashboard itself here, and I hope that you're able to click into the link and use the password there. We'll also send it out by email as well. But so on this first tab of the dashboard, we have a statewide view where administrations are separated by district in those blue bars and in the first 2 blue columns. That first column is the number of administrations provided during the past 7 days. This will update daily, but again is coming with that 4-day lag. The second column is the weekly average for the past 3 weeks or the past 21 days. Again, updated daily on a rolling basis. The orange line there and the orange column is the weekly target. Again, that's defined algorithmically, and I'll get to that in a second. And then that final column is just the percent above or below target in order to reach that 75% coverage. Right now, this is the 18 plus category. So this is what's necessary to reach 75% coverage for that population by May 31st. Okay, next slide. Here is the district view, and this includes a little bit of breakdown as well on the calculation that provides what those targets are. So we start out at the top. There is a drop down here where you can select a district. There is a multi-select option, so if you cover multiple districts, you can select both of them and should see the numbers sum up appropriately. But we start out at the top with the total population. Those numbers come from the NCHS 2019 estimates. So they're as up to date as we can get. And then it's stratified out to the population within the group that we're looking at. So you can see there at the top, there's a 65 plus age group and there's an 18 plus age group. So the population within that age group is highlighted. And then the first orange number there is the target for that age group in total cumulative administrations. That's 75% of the population in that age group. We list the cumulative number of administrations given to date, and the difference between those 2 numbers would be the number of administrations that we need to pursue in order to reach that target. Below that is listed the goal date to reach that target and the number of days difference between the most recent data, again with that 4 days lag, and the goal date. So right now we're looking at data pulled yesterday, but from a 4-day lag. So the most recent administrations in there are from March 14th. So there are 17 days between the 14th and the 31st, meaning that on average, on a daily basis, the state of Virginia needs to supply 11,142 first dose administrations in the 65 plus age group to total that 75% administrations by the 31st. And then that daily number of administrations target is rolled up, multiplied by 7 to get a weekly number. And that's there, the 77,000. Again, this is stratified by health district, and you can select multiple if desired. This right now, what we're viewing is the statewide number. On the right-hand side, you see a couple of graphs. The top graph there is a rolling sum. So it's the 7-day rolling sum of how many administrations were given in the past 7 days. This is a little bit stale because we put the slides together a little while ago, but there is a reference line on that graph to show where that 7-day rolling average is in relation to the target. For 65 plus, most districts are above target, and then you can see below there is the cumulative number of administrations given to date, with the target date highlighted as that blue dotted line, and the target percent of the population as that orange band there, from 75% to 100% of the population. That's available for the 18 plus age group below. Just didn't have room in my screenshot to include those. And there are enhancements planned that will include equity targets as well as age group targets. Okay, next slide. The third image on this, or this third tab in this graphic, this visualization, includes the providers. I'll mention the first two tabs are separated by the location of the recipient's address, the health district of the recipient. This is stratified by provider. So when you select from the dropdown here, you're selecting from providers within that health district. So you can see that it's going to be listed out by provider with contact information, although that has been removed at this point just to make sure that doesn't get accidentally leaked, with the number of total administrations by provider and the number of administrations within the last week. If you select one of the providers here, it will actually stratify the demographic bars to the right. If you select a health district, it will also stratify those bars so that you can see what the distribution of individual providers has looked like. I also not included in the screenshot because there wasn't room, but below the administrations by age group is an administrations by district of residence. So for example, somebody who lives in Richmond City but was vaccinated in Henrico County would show up here if you select districts by Henrico, and then would show up in the bar for Richmond City if that's where their residence was. Again, there are more enhancements to come, and we hope this is a tool that is useful in trying to meet those targets for administration. And we definitely will be taking feedback, questions, or comments. Right now, the COVID vaccine info at vdh.virginia.gov email address is where we'd like you to send those. All right, otherwise, I will be answering questions in the chat.
Thank you, Em. Next up is other PH ops, which includes health information, investigation, surveillance, containment, and informatics and information systems. Jonathan, will you please take the call?
Thank you, Donald. Can you hear me?
Yes, I can.
Excellent. Next slide. Oh, there we go. So the vaccination FAQs were updated on March 17th. Questions were updated to reflect that some communities in Virginia have moved to phase 1C. Other updates included information on the V-Safe pregnancy registry data, Moderna vaccine studies in younger children, and the different categories of vaccine side effects. New questions were added about community vaccination centers and how to access vaccine through these events. The recommendation to get your second dose of a 2-dose vaccination series, even if you've had COVID-19 disease before getting your first dose in the series, blood donation eligibility after vaccination, and for providers about how they can help educate their patients about the history and safety of mRNA and viral vector vaccines. Next slide. On March 11th, HHS and CDC sent a letter out to states and jurisdictions regarding a glitch in the NHSN's ELR message generation from October 23rd, 2020 to March 1st, 2021. The glitch affected over 60,000, roughly 0.8% of the 7.2 million messages that NHSN produced during that time period. And as a result of an infrequent scenario, those 60,000 messages intended for delivery to state health departments were not delivered, including 995 SARS-CoV-2 positive PCR point of care results. NHSN plans to deliver all of the unsent POC messages to state health departments via the standard process of HL7 messaging, via the Association of Public Health Laboratories Informatics Messaging System, AIMS, unless a state health department decides to forego receiving the messages. Next slide. The HAI team recently updated the internal nursing home dashboard that pulls data reported from nursing homes to NHSN, linked here on the slide. Just a note, you will have to be on VPN or Zscaler. The dashboard data are updated weekly on Mondays. CDC added a new question to the NHSN long-term care facility COVID-19 module. Would your facility like outreach by local and or state government for assistance with any of the items below? And this would include staffing shortages, PPE shortages, testing supply shortages, infection control, outbreak management, staff training, or COVID-19 vaccine access. Local health districts are encouraged to frequently check the dashboard for information reported from nursing homes in their district. VDH Central Office can perform outreach to facilities that request government assistance, such as those requesting staff training or assistance with infection control or outbreak management, unless the health district specifically requests otherwise. If your district is able to follow up weekly, please let the HAI team know at hai@vdh.virginia.gov. Next slide. This slide illustrates the number of new resident cases in the red line and the number of resident deaths in the orange line, reported each week from Virginia nursing homes to NHSN. The number of new reported resident cases has dramatically decreased since the middle of January, with the week ending February 28th having the lowest weekly count since nursing homes started reporting in NHSN at 64 cases. The number of reported resident deaths for the week ending February 28th decreased from previous weeks, with 31 deaths reported. Next slide. A REDCap survey has been distributed to all nursing homes and assisted living facilities to collect accurate census data and vaccine uptake for residents and staff. The survey also collected information about vaccine hesitancy reasons in the long-term care facilities and ways VDH can help address those issues. There are some limitations to this analysis. The response rate was only 54%. Out of 854 nursing homes and ALFs surveyed, only 483 have responded. Survey was voluntary and responses were self-reported by the facilities. Data were not verified by VDH. This was a cross-sectional survey that captured vaccine uptake data from long-term care facilities at a point in time. Some facilities responded weeks ago. Uptake rates may have changed since that time. Next slide. The preliminary analysis that you can see on the slide here shows that among residents, 83% have completed the series, 7% have not started the series and do not intend to. Among employees, 58% have completed the series, 35% have not started and do not intend to. And among non-employee staff, 76% have completed the series, 11% have not started the series and do not intend to. We classified employees as staff who were on the facility's payroll. Non-employee staff are those who come into the facility to perform services but are not on the facility's payroll. Next slide. Once the detailed analysis is done, the data will be shared with health districts via an internal dashboard, and a brief report will be shared with the long-term care associations, regulatory agencies, and other stakeholders. Additionally, gathering some vaccine hesitancy resources, and it will be those will be made available on the Long-Term Care Task Force website, and a follow-up survey will likely be created and distributed to capture more accurate data once the long-term care facilities have completed all of their CSV and Walgreens vaccine clinics. Next slide. Outbreak surveillance has had over 2,700 confirmed outbreaks created in VOS as of March 17th. 35% of those are in long-term care facilities, while 23% are in businesses and workplaces, and 16% are in education settings. Next slide. VEDS started receiving COVID-19 electronic initial case reports, EICRs, from the Carillion system on March 16th. These messages are generated from the electronic health record system, and we're estimating around 800 to 900 EICR messages, I should say, per week from Carillion specifically. A COVID-19 variant field has been added to the case information tab in VEDS under the EPI section. The field only needs to be completed when a variant has been identified through sequencing by DCLS, CDC, or another approved laboratory. And a vaccine breakthrough infection field has been added to the case information tab in VEDS, also under the EPI section. If a patient is a breakthrough infection, please answer this question and enter information into the vaccine history section, which is on the COVID tab at the very bottom in VEDS. Central Office is working through back entry of this information, and a dashboard of vaccine breakthrough data is in development. Next slide. As of March 18th, 2021, 97 variants of concern have been identified in Virginia. Of the 97, 74 are B117 and 23 are B1351. And you can see the breakdown by region on the chart there. And just to reiterate from the previous slide, again, the variant field in VEDS is something that should only be updated as central office kind of reaches out to specific districts that have had identified variants of concern through DCLS or CDC or another approved laboratory. Next slide. A U.S. government interagency group has developed a variant classification scheme that defines 3 classes of SARS-CoV-2 variants: variant of interest, variant of concern, and variant of high consequence. We are awaiting additional details from CDC about reporting and tracking of variants of interest. Attributes of variants of interest can be seen in the chart here. They have genetic markers that may affect transmission, diagnostics, and therapeutics, may cause an increased proportion of cases or outbreaks, and have limited prevalence in the US or other countries. We are familiar with the variants of concern, which we have been tracking in Virginia. There are 2 additions to the VOC list, including B1427 and B1429. And finally, a new variant classification shown in this chart is variant of high consequence. None have been identified to date, but identification of one would lead to public health emergency of international concern due to the attributes that you see noted in the center bottom cell. Next slide. In regards to Containment 2.0 hiring efforts, an email was sent to health directors on Monday with a packet of 13 job description templates and funding estimates. A funding memo and detailed list of cost codes will be provided shortly. There are 3 ways of filling the positions. First is a promotion or transfer of existing staff into a new role, which can be done using the contractor change form. The second is a referral form once a candidate has been selected if you are doing local recruitment. And finally, SBS will be providing new position descriptions to only a few contracting agencies to recruit and submit resumes to SBS. SBS will then screen the resumes and send out qualified candidates. Please send requests to SBS to backfill positions. The sooner, the better. We're finalizing the regional and central office job descriptions. We'll also be updating the orange box on the VDH COVID-19 homepage. We appreciate your support in these efforts. Please do not hesitate to reach out to the team at covidcontainment@vdh.virginia.gov with any questions that you may have. Next slide. Since last week's Ebola update, there has been only 1 additional Ebola case reported, specifically in the DRC. This week, the team finalized and posted additional materials to the Ebola chapter in the disease control manual. These include new step-by-step protocol for airport screening at Dulles and subsequent traveler monitoring and DCLS's testing instructions that were updated on Tuesday. The main change for those DCLS instructions involved updating the Ebola virus tests that they will be using, describing their tiered approach to testing for Ebola virus and other pathogens, and specifying required samples for testing, that is 2 whole blood specimens using purple top plastic ETA tubes, and 1 NP or nasal swab specimen in viral transport media. Other updates include a revised person under investigation or PUI form, agreements or recommendations for travelers by exposure risk category, which had been modified slightly since they were posted last Friday, and a template letter in case the health department cannot reach the traveler. 2 resources for the DCM are pending: a template quarantine order that was sent to the Office of the Attorney General earlier this week for review, and the Ebola notification algorithm, where we are awaiting updated contact information. The team also updated the external website to include links to DCLS's testing instructions, a link to the recording of Dr. Peak's briefing to hospitals last Thursday was also added, and a link to the CDC guidance for organizations sending responders out to outbreak areas. Next slide. And finally, just a quick summary of the reported travelers that we've received as of March 19th. As of March 18th. VDH has received information on 29 travelers from CDC's Division of Global Migration and Quarantine. Of those 29 travelers, 26 are Virginia residents, with the majority residing in Northern Virginia. As you can see on the table, 16 out of the 26 have been contacted, and all 16 fall into the low but not zero risk assessment category. VDH has finalized the Red Cap monitoring project for this response, and will work with districts in the coming weeks to give access to staff and provide training. That is all that I have. Thank you, Donald.
Thanks, Jonathan. We will now have the DCLS update by either Dr. Freeman or Dr. Courtney. Would either of you please take the call?
Hi, this is Dr. Courtney. Can you hear me?
I can.
Okay. Next slide. So we've been out for a couple of weeks on these updates, but I did want to just do our last week at a glance. We tested almost 3,000 COVID tests and shipped, you can see a lot less kits. Requests came in, only 5,280. Fair amount of media tubes, over 27,000. And so to date for 2021, we have tested over 35,000 SARS-CoV tests and sequenced 2,341. For updates, we are bringing on additional sequencing capacity through our OneLab partners and university partners, and so we are in progress of getting these MOUs signed and making sure that these partners are using the correct data analysis and quality metrics, as there's a lot of discussion about quality and reporting for sequencing results. We held a training as part of OneLab on March 10th with the Cumberland Plateau and Lenawisco Health Departments, and this marked the completion of all the training needed for the entire region to be able to submit using OneLab to Virginia Tech. And then DCLS, in response to the Ebola outbreak, had an internal training for all of our testing staff on March 12th in preparation for any potential testing requests. Obviously, with our location with Dulles Airport and roll-in screening travelers, we're just being prepared for potential testing requests here at our bioterrorism lab. Next slide. I included the monthly view for March. As you can see, we really only hit our capacity one day in March, so we are at a lot lower volume of testing than we've seen in the past. Next slide. And then this is, again, our contact information. Of course, if you have any questions, feel free to reach out any sample questions to Terry Harper, IT, or portal questions to Emily Hopkins, any scheduling for testing through LaToya Griffin-Thomas, and then my contact info as well as Dr. Bibbs Freeman is included as well. And that's it. Thank you.
Thank you, Dr. Courtney. Next up, we'll have our modeling update by Justin Crow. Justin, will you please take the call?
Yes, thank you, Donald. Next slide, please. Just normal background, we continue to update the model with new and better data. Next slide, please. Nationally, after several weeks of declining cases, we are beginning to see cases decline plateau across the board in the 10 through 20 per 100,000 residents daily rate. So that's matches really where we were at last summer in what we were seeing at case levels. Virginia and our neighboring states are a little bit behind that. We're still seeing some declines there. However, there are signs that we are beginning to see plateaus in Virginia as well. The big question is whether this is a plateau that will just mark a slowdown and then either continue declining, or whether it will be an inflection point and return to a summer surge. We are seeing transmission rates in some states. You can see the coloring of the shading there is above 1, either if you see the orange or the red, above 1 in those states. Next slide, please. Closer to Virginia, as I mentioned, all of our neighboring states and Virginia are in that 10 through 20 range. We see some declines in some states and some leveling off in others. Virginia appears to be leveling off, so just kind of bumping around within that range right now. Next slide, please. And across Virginia, the scale on this has been reduced again down to 20. It says 25 there, but it's down to 20 is the highest top coding of this map. Again, we see no clear pattern in where we're seeing high cases or low cases. Previously, we had seen higher cases really in Southwest Virginia and then kind of move east, but that pattern doesn't seem to be holding. It seems just to be, we're in a plateau kind of phase. Next slide, please. We do like to emphasize that we are still, despite the declines, we are still seeing high case levels. This map shows each county's case level compared to last summer's average case level. And you can see there are a number of counties with 3 times more cases than they had over last summer's average. So still high numbers, some lower, but something to keep an eye on. Next slide, please. We are looking at risk of exposure by group size. This looks at the risk of at least one person being infected in a group of 25. For most of Virginia, that remains pretty low. There are some hot spots here. We continue to see hot spots in college towns this week: Harrisonburg, VSU, Lexington, and VSU and Petersburg and Blacksburg are all hot spots. Previously, we had seen hot spots on the U of R campus here in Richmond and in Charlottesville as well. So colleges continue to be hot spots. College towns continue to show up as hot spots. So something to keep an eye on. Next slide, please. There are no health districts currently in surge. We have 31 health districts declining this week, 2 in plateau trajectories and 2 in slow growth in Roanoke and Mount Rogers. Statewide, we are still in a declining trajectory, but you can see in the chart there, it's beginning to flatten out. Next slide, please. Transmission rates have unfortunately edged up this past week. They remain below 1 statewide, and in most regions of the state. The one exception is the far southwest region. This transmission rate there has been above 1 or very close to 1 over the past few weeks. So definitely need to keep an eye on what's happening in Southwest Virginia. Next slide, please. We continue to track symptom onset to diagnosis. It continues to edge down. So in February, the average is 3.4 days compared to 3.9 days in January. So we're doing a good job in picking up cases and identifying them quickly. Next slide, please. The UVA team has partnered with some folks at Carnegie Mellon who are running a Facebook survey. They've gotten an IRB approval through. They've gotten some increased access to that data. So this is showing not just the vaccine acceptance level for Virginia, but also information on the number of Virginians who have already been vaccinated. So when you combine those two together, nearly 80% of Virginians have either already been vaccinated or will probably or definitely get the vaccine when it is available. So a slightly different look at that. It's definitely good to have that higher rates. Of course, this is a Facebook survey. It is low end, and we expect that we are missing some, not capturing some key populations as much as we would like to. Next slide, please. As it is now, or as it was on Wednesday, actually, we had almost 20% of Virginians had at least one vaccination dose, and about 6% of Virginians have been recognized as confirmed cases. So we expect about 3 or 4 more infections per confirmed case. So that is a significant amount of the population, and we do think infections are likely concentrated among essential workers, people living in multi-general households, and other vulnerable populations. So that is likely having an effect on transmission rates. Next slide, please. We've been tracking the B117 variant specifically, looking at variants of concern generally, but the B117, based on some national modeling, we expected it to be the dominant variant in Virginia by the end of March, although evidence is a little sparse. We seem to be on track for that. Still a little below what we'd expect at this point, but still on track to be the dominant variant of more than 50% of cases by late March. So we're still expecting that to happen. Next slide, please. The team has updated their scenarios quite a bit. They had been modeling this fatigue control scenario as the highest level of transmission seen throughout the pandemic, but considering we're entering the summer months and there was very different transmission levels over the summer months than the winter months, they've limited this to the period between May 1st and September 30th. So they're looking at that highest transmission rates in that period specifically by county, and then modeling that forward to kind of provide a pandemic fatigue and loosening restrictions, loosening prevention efforts scenario. Next slide, please. They continue to model the vaccines based on past administration and some information on the schedule going forward as well. And they just model it at per capita distribution across all counties and assume that continues within the counties. So right now we're on pace to basically vaccinate 32,000 first doses per day. Next slide, please. So we end up with 4 scenarios. At this point, we've removed some of the best past scenarios that you've seen previously because they were tracking very close to the adaptive, which is good news. But the adaptive is still, current situation projected forward. The adaptive fatigue control includes those the fatigue control scenario. And then, of course, the adaptive variant includes the variant becoming dominant alone. And then the worst case scenario is the adaptive fatigue control and variant, which includes both the fatigue control and the transmission boost from the B117 variant. Next slide, please. So just looking at the projections, if we are able to remain on our current course, we would expect to see cases below last summer's rates really by the end of April, beginning of May, and continuing to taper off after that, with really the pandemic tapering out in July, which would be very good news indeed. Next slide, please. In this map, we continue to show the deviations from the adaptive model's expectations. So this is really looking at deviations from trend. We do expect there to be some deviation from trend every week. So if you see your county or the county in your health district listed here, just something to keep in mind and keep an eye on. I do want to note that the bland white there in Mount Rogers, that local health district is also in a slow growth phase, so just something to keep an eye on. Next slide, please. So this shows the results of the fatigue control. If we model the adaptive with just the variant, we continue to see declines similar to what we see in adaptive, just a little bit slower. The only time we see another surge is if we include the fatigue control scenario. So if people loosening their restrictions, we would expect to see another summer surge, about what we saw last summer in July, and the pandemic would essentially continue into August and September. Next slide, please. However, if you combine those two, you have fatigue control and include the variant, we do expect a large increase. We would see peaks not quite as high, but approaching what we saw this past winter. I also like to point out that it is a wider peak, so we would see sustained high rates for a longer time. There is some geographic variation in that. I did ask the modeling team about that this morning, about really the Eastern Virginia part. And we are seeing, there's a few possible reasons for that. We're seeing some high rates in some areas of Eastern Virginia, and we're seeing some slower vaccine rollout, particularly in Norfolk, Portsmouth, a few other counties, localities in the region. So that might explain that. We also discussed the possible effects of the poultry farm outbreaks and how those might be impacting the highest spread that we saw last summer. So the UVA team will be diving into that a little bit more, but I just wanted to mention that those geographic spreads there. But obviously this is the worst case scenario and we hope to avoid it. Next slide, please. Just looking at those all together, we show that the peak last year was 13 cases per 100,000, the peak last summer. Right now, we're still above that in Virginia at about 16 per 100,000. And you can see the comparison of the peaks on that bar chart, or that pull out to the left. Next slide, please. And with the fatigue control and B117 variants, we're going out further than we did last week. Thank you, Christina. But we do expect hospitals to be capacity to maybe be exceeded in the far southwest Virginia and eastern Virginia in that scenario, but hopefully that is a scenario we can avoid. Next slide, please. All right. As mentioned, this will be our last LHD meeting, so I've enjoyed presenting and sharing information with you here. We do have a meeting every Thursday at noon as well, where we provide an update. So if you're interested in continuing to get these updates, and it would actually be a longer update with the UVA team and our partners at RAND both presenting their results. Please contact Emily Sheffield at the address listed there to be added to that meeting. And if you are added to that meeting, we'll also email you the slides that they provide every week, which we do already publish on our Data Insights page. So thank you. That's all I have, and I'll answer questions in the chat.
Thank you, Justin. At this time, we'll do questions and answers. If you've joined via WebEx, please type your questions in the chat box. If you joined by telephone, please email your questions to donald.moore@vdh.virginia.gov with the subject line LHD call question. We'll go ahead and mute all of the lines now. We'll leave the session open until we see a slow in the questions that come through. Otherwise, everyone, please have a great day.